And we have just about a minute. Before we get started. This is going to be so interesting. I'm really looking forward to hearing your information that you're going to provide today. So welcome, everyone. Dr. W. Larry Daniels is our presenter for today. And on the way to becoming a nurse for 33 years and a nurse practitioner for 29 years, Larry Daniels began his adventure in healthcare at the age of 16 in a volunteer rescue squad. As an emergency medical technician, he was the attendant in charge of an ambulance at the age of 17. He is currently the director of outpatient mental health services for the James Barry Robinson Institute in Norfolk, Virginia. For over 90 years, Barry Robinson has served children and adolescents of Hampton Roads, Virginia, and the world as an orphanage, residential mental health facility, and foster care agency. For the past 2 years, Larry has led the formation and success of a co-op-based multidisciplinary practice environment for outpatient mental health providers to serve patients across Virginia and the surrounding states. He joined the faculty of Old Dominion University at the age of 23, where he led the emergency medical technician program for the university for 15 years. After a life-changing adventure teaching first aid and CPR in Liberia, right before their civil war, he sold his full-time practice as an insurance agent and investment broker and went to nursing school, followed by 17 years in an emergency department. He has served on numerous nursing faculties over 25 years and has served as department chair for 2 schools of nursing. He has also served on the board of directors for NAP and the NAP Foundation. As part of his role as director for mental health services, he is currently an autonomous practice pediatric nurse practitioner and pediatric mental health specialist, providing medication management and nursing services in child and adolescent mental health. He has a book of over 700 patients in Virginia, North Carolina, and Maryland. He has been with United States University for 5 years, primarily facilitating the Master's Nursing Theory course. We're so happy to have you present. Take it away, Larry.
Good morning. I will have to amend a little bit there. James Barry Robinson has decided to alleviate themselves of outpatient services. Much of it has to do with a military involvement situation. And I am moving all my patients over to United Community Solutions, which you see there, which isn't going to matter to any of y'all. And the initials, NAP, for those who are not aware of it, that's NAP. How fitting for a pediatric organization, which was the first nurse practitioner association established many years ago. Anyway, we're going to talk today about an overview of mental health pharmacology, and I have no invested interest in anything that is being said today. I have no sponsorship from any drug companies or anybody else that has a financial interest in this presentation. Hopefully, by the end of this presentation, you will have the ability to describe sort of the impact of mental health on the general population, in particular children, as that's my specialty. That's where I'm going to concentrate. We'll talk a little bit about neurotransmitter anatomy and physiology, some common mental health disorders, psychopharmacology mechanisms and actions, and how some of them are working, and then specific psychotropic medications. And if at any time you have a question, please ask. I do so love a distraction. All right, we're going to go back to 2018, pre-COVID. This particular chart comes from the old Whisker system from the CDC. This system is no longer available, unfortunately, to create these types of charts. This, I think, is probably one of the most significant ones. Many years ago, I was very involved with child passenger safety, and that's where I discovered this chart, and it started, we called it the big blue line because of the unintentional injury impacts. But what I'd like for you to look at is the green, suicide. Ages 15 to 24, 6,211 suicides in the United States in 2018. These numbers are not getting better. Mental health is a significant issue. I don't have a solution for the entire problem. I have some feelings and some hypotheses as to what may be the underlying cause of some of this, but that has no research bearing at this time, though there's some coming out that's making it kind of interesting. About 1 in 5 U.S. adults experience some form of mental illness each year. 1 in 20 experience serious mental illnesses each year. 1 in 6 youths between the age of 6 and 17, and 50% of all lifetime mental illness begins at age 14, and 75% by 24. And suicide is the second leading cause of death among people between the ages of 10 and 34. This information, like just about every other health statistic right now, is skewed since COVID. So some of these numbers are a bit over 5 years of age. She mentioned that I'm moving, or I have a book of over 700 patients. Right now, the book is about 850 children that I see as one single provider. And to me, it's astronomical that we've got that many children who are experiencing some form of mental health issue, or that it is that society and the environment that they're in is so adverse to them that they require some form of medication to help to cope with the situation. Now, today we're going to talk about some specific disorders: ADD, ADHD, oppositional defiance, conduct disorder, autism spectrum. Near and dear to my heart, I have over 300 autistic patients. Mood disorders, schizophrenia, anxiety, and disorders of sleep. And we're going to talk about the disorders in general. Then I want to talk about the medications that are used for those. Now, as a nurse, as a general provider who is not normally working in mental health, what I hope that you get out of this is a overlying scope of how different medications affect these disorders and sort of what the medications are used for. I am going to get a little deeper in a couple of points that if you are working with mental health medications routinely, you may get something new out of it. I'm not sure you'll get anything outstandingly new from this, but hopefully it'll help as a refresher for those who are working in mental health. ADD and ADHD, lack of focus, impulsivity, easily distracted. Let me give you my Google interpretation. You are Googling something and you get an answer. And over in the corner, there's this little ad or something shows up, or a little sideline box shows up, and you say, hey, that looks interesting. And so you click on it. An hour later, you stop clicking on those things and you realize, wait a minute, I'm supposed to be doing something else. That's ADD. I have the world's worst case of it. I've been in too many careers not to say that I don't have attention deficit, but that's essentially what we are dealing with the attention side. Hyperactivity, inability to sit still. You combine the two together and you have ADD/ADHD. And then hyperkinetic disorder is where you can't stop moving, but you can pay attention. And that's the child who needs the bouncy ball to sit on at their desk, but they get all their work done and they do well in school. This combination of or disorder affects about 6 to 7% of the population, boys 3 times more than girls, and it is possibly an impairment in the norepinephrine and dopamine pathways. However, it could also be nature. I want you to compare, for example, a accountant versus a fighter pilot. The accountant, very focused, stays on the numbers, takes a bomb going off next to them in order to get them distracted from what they're doing. Hyper vigilant. On the other side, you have the fighter pilot, sees everything in their environment. They're the people who are going to get the 4-leaf clover off the sidewalk. They see everything. They respond to everything in their environment, and they don't stay on anything for very long at all. Both of these traits, if we go back 10,000 years, and we have the fighter pilot who is hunting for his food. Well, let's go to the accountant first. The accountant is a hunter. He's at the herd of buffalo. And he goes, I want that buffalo. I want that buffalo. I want that buffalo. He gets that buffalo. He eats well. The fighter pilot's going, I want that buffalo. I want that buffalo. Oh, that one looks better. Oh, squirrel. Doesn't eat quite as well. Take the same 2 people and you put the accountant on the farm and he's hoeing the field and he's so concentrated on that field that he doesn't see the lion come and get him. But you get the fighter pilot, he's hoeing the field and he sees what's going on around him. He eats well because he gets his crops done, but he also is not at risk. So they are 2 personality traits that fit different environments. And I would like everybody to go into a kindergarten or a 1st grade classroom today and see how many distractions are on the walls. I grew up in an environment where you had the teacher, the teacher's desk, a strip of letters across the top of the blackboard that said the way I was supposed to write my letters, and a bulletin board with 5 or 6 sheets of paper on it. And the only thing in the classroom that moved that you could look at was the teacher. Totally different environment. Does that affect children in general? And does that mean that more children who are more on that fighter pilot side are going to be recognized with a deficit and then need medication? I don't have an answer to that, but it's a question that is being asked. All right, ADD, ADHD to oppositional defiance disorder. This is a defensive mechanism. When a person receives new information that contradicts what they've learned in the past, they immediately put a wall up. And essentially, this is kind of what is happening with oppositional defiance. It's raining outside. No, it's not. It's a way of deflecting information, slowing information coming into a person that helps them cope with it. Well, typically an oppositional defiant child is going to be angry, irritable, defiant, they argue with everything, and they have frequent temper tantrums. But they do not have property destruction or aggression towards other people. And so there's really no medication for this, but it is a very common disorder in childhood. And it's thought to be a little bit of an imbalance between that behavioral activation system and the underactive behavioral inhibition system. We're not going to get too deep into the anatomy on that, but those are the systems that are working with each other to balance out reactions. Conduct disorders is sort of the next step here. This is where we actually get property damage and or aggression towards other people. very complex etiology here. There are reductions in serotonin and cortisol levels that have been measured. These folks are unable to regulate their mood. They have very impulsive behaviors. They have very weakened signals of anxiety and fear. They really don't fear. They don't see consequences. And decreased self-esteem seems to be pretty common, about 1 to 10% in the general population, but anywhere from 23 to 87% in the juvenile detention facilities. Autism spectrum. This is a group of pervasive developmental disorders. And that is the best way to think about this entire group of disorders. It now includes autism, Asperger's, and childhood disintegrative disorder. If you get psychologists and psychiatrists in the same room together, you will frequently get a lot of argument about whether Asperger's is in this or whether it's separate or not. It doesn't matter to me because the medications are the same, but there is controversy on how Asperger's was lumped into autism with the latest DSM coding. So it is two things: a communication disorder and a pervasive delay of social skills. So you get antisocial behavior or a lack of recognition of socially appropriate behavior. Repetitive behaviors, they will perseverate. They will get on a topic and not let go of it. And then they may or they may not have cognitive delays. We don't know why this happens. The only contributing factor that we have been able to identify anywhere is the use of acetaminophen, also known as Tylenol, during pregnancy. That is the only potentially causative factor that has been identified. And even that is very slim. There is a higher number of cases in families that have histories of autism. It's about 6 per 1,000 for autism spectrum disorder as a whole. My personal experience with this is it is very underreported, underdiagnosed. And there are many folks who are present without recognition in the general population. Daryl Hannah is the national spokesperson. She was diagnosed when she was an adult, after her acting career started. Some of the others that you may see in the general population, or not the general population, but famous individuals include Dan Aykroyd, Bill Gates, Steve Jobs, Elon Musk. Einstein is anticipated to have been autistic by some of the descriptions of his behaviors over the years. And there are many others. Mood disorders include bipolar, major depressive disorder, disruptive mood dysregulation disorder. DMDD is actually a fairly new diagnosis that is only good through the age of 17. Once you turn 18, they no longer use that diagnosis. You are evaluated for bipolar at that point. But it's sort of a way of describing bipolar type behavior in an individual who is too young to be diagnosed with bipolar because there are too many developmental skills and developmental behaviors that are conflicting or confusing for a bipolar diagnosis. Less severe diagnoses that you may hear, dysthymic or cyclothymic disorders. In 2011, we're going back quite a few years, but ages 1 to 17, there were approximately 112,000 hospital stays and admissions for this. It has only gone up. It is possible that these mood disorders may be substance induced or a result of a medical condition. With the increase in the use of cannabinoid substances, we see an increase in mood disorders. And there's still a lot of controversy on where the causes on that are. We see it much higher in the, let's call it the street level marijuana. And a lot of that is because those are not regulated, they're not tested, and they frequently do contain other substances. We don't know for sure. There's a lot of conflicting literature out there in regards to that particular substance use and mood disorders. Schizophrenia. Now, this is a condition that personally I have some experience with, but you typically don't see it in children. It's not until about the age of 16 to 18 in that neighborhood that you really start to see the signs and the symptoms come out. This is abnormal social behavior and the inability to recognize reality. The person who is walking down the street, having conversations with themselves, not talking on a cell phone. When cell phones came out and the earbuds came out, there was a lot of misdiagnosed schizophrenia until people realized that what the folks were doing. But there's confused thinking, and incongruent expression is a hallmark here, where a person will sit there and say, "I'm going to kill you," smiling at you, and mean it. Their facial expressions, their nonverbal communications don't match what they may be saying or communicating otherwise. Typically beginning in young adulthood, rare presentation in children, may be linked to an overstimulation of dopamine receptors. Also, I didn't mention just a second ago, you do have visual and auditory hallucinations, very common with schizophrenia. But just because you have hallucinations does not mean that you have schizophrenia. There are other causes for that. And it has been reported, and I have had a case or two cases in particular, that it was induced permanently by marijuana use. I'll tell you this example. I had two friends, two young men who have no family ties, no genetics in common, same class, and they smoked marijuana. And both of them developed severe schizophrenia. They were not in touch with reality. I followed them for 4 years, and as the last I heard, there had been no relief on those symptoms. The only thing that was common between the two was smoking the same batch of marijuana. Now, was it the marijuana? Don't know. Was it something added to the marijuana? They don't know. But there have been other cases which have exhibited similar outcomes. Anxiety. Oh, I see more kids with anxiety. It is a fear response. Fight or flight syndrome. It is presents with very nervous behavior. It can have somatic complaints, stomach aches, lack of sleep, inability to sleep, worry. May show up with obsessive types of behaviors, such as have to go around and check every lock in the house before they leave the house. A multitude of different types of signs and symptoms can occur with this. It is noticed that in the amygdala, there's an increased blood flow in response to unpleasant sensations, and they have been able to map this and identify it as being heightened or increased in folks with anxiety. And it's thought to be a protective mechanism. The body puts up this fear response, but it is a very high level of response and can be false positive. Even when learned situations conflict and say there's no danger here, the body may still respond. Anxiety and panic attacks are fairly common. And long-term, though, it has been found that counseling is more effective than medications in the long-term reversal of anxiety symptoms. And this is the amygdala. If you're not familiar with it, looks like a scorpion in the brain. And then there are disorders of sleep. If sleep is not under control, nothing is under control in the mental health environment. Of everything I deal with, the most common underlying condition is insomnia, inability to sleep, or sleep resistance. And especially in your teenagers, it is sleep resistance. They just don't want to go to sleep. And it can present in one of two ways: sleep delay, you put your head down, but you can't get to sleep, or sleep interruption, you wake up in the middle of the night. Now, it's common to wake up 3 times a night. We go through normally 4 cycles of sleep. It takes about an hour and a half to go from alpha level sleep down to rapid eye movement sleep. Then rapid eye movement sleep lasts about 15 minutes or so. Then you bounce back up to alpha, and you wake up at that time. You turn over, go get a drink of water, go potty, then you go back to sleep. And that waking up 3 times is normal if you're able to go back to sleep. In colonial times, you went to sleep when it got dark. You usually went through about 2 cycles. Then you burned the midnight oil. You got up, you fed the cows, made sure the sheep were still in the corral or wherever they were, and everything was squared away, and you did some chores, and then you went back to sleep for 2 more cycles. And that's been documented in a lot of historical literature.
Larry?
Yes.
There's a question, Maicha has a question. Is there any current research on how much doom scrolling has impacted insomnia?
How much has what impacted insomnia?
Doom, D-O-O-M.
I don't know. I rarely come across thoughts of impending or general doom. I have a couple of patients with high levels of anxiety who, and if I'm on the right pathway of what you're talking about, who have this feeling that society is doomed. I don't see it.
Do you want to explain maybe what you mean by doom scrolling? Go ahead and unmute yourself and explain that, please.
Yes, thank you so much. And thank you so much for this amazing, amazing information. I'm literally hanging on to your every word. But doom scrolling refers to it's a social media activity where you just can't put your phone down.
Oh.
You just keep scrolling through. You say, I'm gonna look for 5 minutes before I go to bed, and next thing you know, you've been 2 hours on Instagram, and that's what doom scrolling is.
Okay, thank you. I have not heard that particular term.
Okay,
but I'm very familiar with the phenomenon. Okay, we've got a couple of things going on here. First of all, we're dealing with immediate feedback. Nobody has to wait for an answer. 1. We have intermittent rewards because, oh, I'll just go to this next one. Oh, that's really interesting. So you get this intermittent reward system going on. Then we've got a physiological condition having to do with blue light. Now, if you can picture the back of the eyeballs, the optic nerves come off of the back of the eyeballs and they cross together in the front of the brain in an area called the optic chiasm, C-H-I-A-S-M. All right, that lies right against the hypothalamus and the pituitary glands. Guess what regulates melatonin production? The light going across that particular area that touches the hypothalamus and the pituitary. Well, in particular, the blue light frequency of LED lighting stimulates that particular part of the optic pathway and the brain and decreases melatonin production. So if you're watching your LED device and you don't have the blue light filter on, you're actually decreasing your ability to sleep. So that's another factor in there. I spend a lot of time working with parents on router control. Now, I can't do anything about adults, but yes, there is a physiological reaction here that keeps them awake. So what do we do for kids? One, the routers that are on today for virtually all high-speed internet connections have the ability to go in there and turn off devices on a time schedule based upon their MAC address. The MAC address is a set of numbers that is unique. And I say numbers because it's base 16. So 11 is A, or no, 10 is A, 11 is B, C, so on up to 16 areas in there. So that's why you get letters as part of this numeric address. The MAC address is unique for every device on the internet. So you can go in, a parent can go in and turn off their kid's internet connection or availability to a device on certain hours. So they're at home between 10 o'clock at night and 6 o'clock in the morning, there's no internet connection. It's one of the best things that parents can do for their kids is disconnect them. I am watching worldwide academic responses to internet use. And we are seeing that countries that are using internet-based learning are falling and failing in their skill sets. And we're seeing it here in the United States as more and more school systems are getting away from textbooks and they're going to computer-based instruction. Teachers are not teaching, they're facilitating. And I say that working for a university that does internet-based teaching. So where does that put us all? Put us all. But we're finding that scores are tanking. Several countries, Sweden, for example, have gone back to textbooks, and they're finding scores are increasing. I don't know where we're going to go with that. It's expensive no matter which way we go, but that's a significant issue. When we are on the internet and we're getting rewarded, we are triggering intermittent reward systems. Gaming, in particular, is an intermittent reward system, and they loop you in onto the games based upon this intermittent reward. They make a lot of money off of it. Most major computer advances actually are invented in the gaming community. But that intermittent reward system, if you were my age before the internet, they called it gambling. And that's what it is. It is essentially the same as a gambling type addiction. And you get hooked into it, you cannot get out of it. And I spend a significant amount of time talking to parents, trying to get them to disconnect their kids. The other piece of this, and this is not part of this presentation, but a huge amount of our communication is pheromones. A lot of our attraction to others, their willingness to stay in their presence is based upon pheromones. Those hidden, unseen, call it smells, chemical connection. And if you don't believe that they exist, go to a college female dorm 3 months after school starts, and you will find that virtually everyone is on the same cycle. Because pheromones are incredibly important. They're important in our interaction with other people. We are disconnecting from that part of our communication cycle online. And then we have the ability to be easily miscommunicate because a lot of our conversation is nonverbal. A great example of this is 2 words. Pretty good. Pretty good. Same 2 words typed over a text message means 2 totally different things because we're missing the context. We have got to get kids back together. COVID did not help us at all in this particular issue. Did I touch on your topic that the question that you asked?
Yes, sir. You gave a lot of nuggets directly related to my question. So thank you so much for sharing your expertise.
Sure. All right, so moving on. Oh, parasomnias, disruptive sleep events, sleepwalking, nightmares. There are a multitude of different parasomnic type events. Get rid of interruptions. Get a fan in the room so that you've got air moving to move carbon dioxide away from the mouth that's being exhaled. You've got some brown noise, and you'll find now that there's a lot of information out there about white noise, brown noise, green noise, and now I've heard blue noise. There are different levels of noise or types of noise that can help facilitate sleep. But the key issue is making them go to sleep very young so that they get used to it. It takes approximately 3 months of sleeping exactly the same way for the body to regulate. And you can experience this after you've been on a job and you start getting up at the same time every morning to get ready for that job because it's the consistency, and then you find out that you don't need the alarm clock, you wake up anyway. Development. This is a key issue in children when dealing with mental health issues. A lot of mental health issues are not mental health issues. They're developmental issues. All children develop in the same order. You crawl before you walk before you run. You say 1 word before you say 2 words. You say 2 words before you say 3 words, or before you say a sentence. You call 2 animals a dog. A little bit later, you distinguish between them as a dog and a cat. And then a little bit later, you start to distinguish the difference between a German Shepherd and a Chihuahua. They are developmental steps. Every child develops in exactly the same order. They all develop at different speeds. Not only that, they develop within the skills at different speeds. Little Susie may potty train at 13 months, but Johnny was 18 months. But Johnny started running at 13 months, where Susie didn't start running until 15 months. Everybody progresses in the same order, but they progress at different times. A lot of what we may see being reported from the school system is not necessarily a mental health issue as much as someone is just developing a little bit faster or a little bit slower in a particular area. That does not mean they will not develop. It just means they're doing it at a different speed. So we have to be a little careful with the diagnosis of mental health issues at young ages based only on school performance. Many of these issues are best dealt with a tincture of time. Best medicine in the world for a lot of these issues. All right. Neuropharmacological agents. Now, basically what I want you to picture here is nerve. You have a transmitting nerve. You have a space between the transmitting nerve and the receptive nerve. We can call that the neuron in the postsynaptic cell. But essentially, a chemical is released by the transmitting nerve. It crosses the synaptic cleft for the synaptic space, the space between the sending cell and the receiving cell, and gets picked up by a receptor. Different drugs work on different spots and do different things. So we can block the reception of a neurotransmitter. We can, you saw the T there and the T shape on the receptor. We can actually create a drug that has a shape it looks like that, fits into that spot, blocks everything else from getting there, and yet does nothing. We can increase or decrease the availability of neurotransmitters, the chemical that's being transmitted across the synaptic cleft, by increasing the secretion on the sending nerve, or by increasing the recycling of that chemical. And I'm going to show this in the next slide. We actually release neurotransmitters between the nerve cells, and we have scrubbers that go in there and recycle the stuff. We can change the rate at which these cells operate or transmit the nerve impulse, but we cannot change what they do. They cannot change the function. So here is an example. We have phenylalanine being converted to tyrosine, which gets converted to dopamine, into L-DOPA, which gets converted to dopamine, which then gets converted to norepinephrine. And we're going to deal predominantly with norepinephrine, dopamine as the two predominant neurotransmitters for the majority of nerves. And then we've got serotonin, GABA, and a couple of others that we deal with for very specific nerves. Excuse me. So this norepinephrine gets released, especially when we're talking about ADD, ADHD. And the postjunctional or postsynaptic cell gets stimulated. Well, you'll notice over there on the side, there's a receptor site, that alpha-2, which scrubs the excess norepinephrine out of the space between the two. So we can increase the amount of recycling that's done so that we decrease the norepinephrine. We can block the recycler. We can increase the production in the cell itself so that it produces more norepinephrine. And just as a matter of sheer, just kind of point this out, nothing totally bearing on this lecture, but look at the difference between norepinephrine and epinephrine. It's a 1 carbon and 2 hydrogens difference between the two. Very, very similar, very, very closely related. That's a trivial point, which some people at some point may find interesting. Now, we're talking here specifically about adrenergic nerves and brain activity, but the same principle applies to some other transmitting sites, whether it be serotonin, GABA, or others. Now, there is also a chemical produced in the cell. And if you see the term esterase, that is a chemical or an enzyme that breaks down these neurotransmitters. I don't want to get a whole lot deeper into that than this, or we'll be here all day. But essentially, this esterases, if you ever hear that term in the pharmacology, that's a chemical that breaks down neurotransmitters. Now, catecholamines and the predominant catecholamines are broken down by one of two chemicals, catecholomethyltransferase. Epinephrine, norepinephrine, and dopamine are reduced by that one. Monoamine oxidase. Now, I'm bringing this one up in particular because of mental health medications and the fact that we are having an increased issue with MAO inhibitors. MAO is found in the cells, and they breaks down serotonin, melatonin, norepinephrine, epinephrine, dopamine, tyramine, tryptamine, phenolphthalein, and benzylamine. These chemicals are broken down and destroyed by MAO. Where that gets important is a little bit later. Hang on to that thought. But of all these neurotransmitters, there are approximately 50 out there that we know of. The Human Genome Project currently suggests that there are more than 200. The primary neurotransmitters involved with mental health, norepinephrine and dopamine are stimulants. Inhibitors are serotonin and GABA, and there's one that is becoming more interesting, and that's NMDA, which I will talk about briefly in relation to one medication. So when we go and we are treating somebody, we're basically going to treat them with one of these 6 categories of medications: psychostimulants, mood stabilizers, antidepressants, anti-anxiety, anti-epileptics, or anti-manics is another term for that, and somnolence enhancers. So the disorders: ADD, ADHD, psychostimulants, and the centrally acting alpha-2 adrenergic agonists are very common medications. You'll see a list of them in a minute. Oppositional defiance, conduct disorder, autism spectrum, mood disorders, schizophrenia are treated with antipsychotics, along with mood disorders are also treated with antidepressants and antimanics. Anxiety, treated with anxiolytics. Serotonin reuptake inhibitors, which are antidepressants. Tricyclic antidepressants. And then sleep disorders, hypnotics, and centrally acting alpha-2 adrenergic agonists. That's clonidine or Intuniv or 10X. We frequently will see multiple comorbidities in mental health patients. There is no one single recipe for the pharmacological treatment of virtually any of these mental health disorders. It is frequently a combination of medications and a treatment of the behaviors that are interfering with the activities of daily living. One of the things that I have noticed is that many people try treating the diagnosis and miss, because the diagnosis in mental health is very much based upon how a person answers questions on a particular day. That's a whole nother lecture. All right. Psychostimulants include your Adderall, dextroamphetamine, amphetamine, dexedrine, which is half of that, dextroamphetamine, lisdexamphetamine, also known as Vyvanse. Reuptake inhibitors include atomoxetine, also known as Strattera, dexmethylphenidate Focalin, dexmethylphenidate Ritalin, and now Qelbree, which is a brand new medication, about 3-4 years old. It is a non-stimulant. These reuptake inhibitors prevent the body from recycling the norepinephrine that's being produced. Ritalin, or methylphenidate, is the preferred one to start with for children, but there really is no significant difference on which one you start, and there is strictly a flip of a coin as to which one's going to work on any one particular individual. You don't know until you try it. Caffeine is an incredible stimulant. The Navy runs on it. I live here in Virginia Beach, Norfolk, Virginia. You can't turn around without seeing something associated with the Navy. Coffee is the lifeblood, and it does it through the blocking of adenosine A1 and A2A receptors. The problem with using caffeine is that it has substantial side effects outside of the stimulation, and also that there is no uniform dosing available with caffeine. Two drugs in the same class of medication, which used to be used for asthma, theophylline and aminophylline, are in the same classification as caffeine. And then you've got cocaine. All right, it doesn't just work on norepinephrine, it prevents the reuptake of dopamine, serotonin, norepinephrine in the MDA, and a few others. It is a general block all the stimulants because it is a stimulant in and of itself, and gives you or block the reuptake. And it just gives you this overwhelming stimulant effect. We still use it, and it is prescribed virtually only for nosebleeds anymore. I've given it a couple of times in the emergency department, more paperwork than it's worth. Now, some of these work, and we're starting to get close to the time, so I'm not going to go into a whole lot of detail here, but we go through each of these individual neurotransmitters, and these are the medications that work on them. This slide set is available, so you can go back over those. Adverse effects: hypervigilance, euphoria, hypertension, tachycardia. Sudden cardiac death is rare for all except for cocaine. Moodiness and irritability on withdrawal is almost universal. And that's why in the afternoon, frequently your kid comes home from school. He did great in school, but he's a monster when he comes home. Clonidine, guanfacine are centrally acting alpha-2 adrenergic agonists. They specifically help with ADD, ADHD, sleep. They have a little bit of a somnolent effect, and they are the predominant medications for tics. Clonidine, for us old geezers, is frequently used for blood pressure. And hypotension is the side effect. Adverse effect: sudden cardiac death, incredibly rare in children, because heart output in a child is different than heart output in an adult. And I can go through the dynamics if anybody's really interested, but we can talk about cardiac output, rate versus volume all day long, but not in this class. Some less used medications for ADD, ADHD include bupropion, also known as Wellbutrin. It has a tertiary effect for ADD, ADHD, and tricyclic antidepressants, in particular, desipramine and nortriptyline, were used before stimulants for ADD, ADHD. And then amantadine seems to be coming out now after several studies. It affects anger, decreases anger and irritability, particularly in autism, And it also can help with ADD, ADHD by increasing focus as a result of its effects on NMDA receptors. It is in the same family as ketamine. Anybody who's working in mental health knows that ketamine is now coming up with some interesting research. Amantadine is in that same family and has some of the same effects. Amantadine was originally created to treat the flu, but then we found that it didn't work so well for that, but they found out that it did help with anger and irritability in autism. Antidepressants, selective serotonin reuptake inhibitors, SSRIs, Prozac, fluvoxamine, citalopram, also known as Celexa, Lexapro, escitalopram, Zoloft. These are all your selective serotonin reuptake inhibitors. They prevent the body from recycling serotonin. Then the next step up from that is serotonin norepinephrine reuptake inhibitors, most common ones being venlafaxine, duloxetine, also known as Cymbalta, and Pristiq desvenlafaxine. Tricyclic antidepressants, rarely used anymore. Monoamine oxidase inhibitors, an interesting class of medications. They actually were discovered accidentally from tuberculosis treatments, and we'll talk about that one in a second. St. John's wort, over-the-counter, extremely dangerous. It can produce a serotonin syndrome, coma, significant side effects. Antipsychotics, Abilify, for example, frequently used in low doses. And then essential oils, lavender and chamomile. These you have to be very careful with, especially if somebody is taking an antidepressant with them. They can actually produce, if you're using them as an oil, skin absorption. I'm not referring to aroma therapy. There have been documented cases of them causing serotonin syndrome. Here are your SSRIs. Prozac's very common. Problem with Prozac is it takes 4 to 6 weeks to start working, and then when you want to come off of it, it takes 25 days to eradicate it from the body. The others are much faster in both directions. Cardiac events are very few. Serotonin syndrome is the most common adverse effect, and that's even rare. And it's one of the reasons that we really like to use these is because there are very few side effects and very few dangers, even in overdoses. Serotonin syndrome can occur within minutes of the elevation of serotonin levels, and it can cause coma, high fevers over 106 degrees, shivering, twitching, hyperreflexia, what's called clonus, and then the emergency department would treat this. This is a potentially life-threatening emergency. If you suspect it, call an ambulance. If you're in the hospital, call the code. SNRIs, selective norepinephrine, or serotonin, not selective, serotonin norepinephrine reuptake inhibitors. Very similar effects as SSRIs. The biggest issue with them is that the norepinephrine produces a much greater effect. Tricyclic antidepressants, rarely used anymore. The big issue is if they are overdosed, they have significant cardiotoxic effects. Rarely used. I've got a couple of kids on them because nothing else has worked, but we try to avoid them. MAO inhibitors. The one thing I would like for you to remember with this is isoniazid. I never can pronounce that. All right. That is the predominant treatment for tuberculosis. We are increasing our tuberculosis treatments. There's more of tuberculosis effects occurring. People are on this. If you mix this with particular types of cheese that have tyramine in them, you can produce severe effects where the norepinephrine is released and it is not recycled. And it can cause significant adverse effects. And this is basically MAO eliminates norepinephrine, inactivates it, and MAO inhibitors prevent that from occurring. All right, and I'm gonna let y'all read up on that. Some other antidepressants are out there: Wellbutrin, mirtazapine, and trazodone. Wellbutrin, a couple of points that need to be mentioned. It is predominantly for motivation. It works on dopamine. Serotonin, happy hormone, it helps to prevent depression. Dopamine works on motivation. Wellbutrin also has the potential side effect of increasing libido, female libido, and I have had one case that brought this to my attention, in which, as a result of using Wellbutrin, the young lady had a title change to mother, and that was not an intended consequence. St. John's wort, it inactivates estrogen in birth control pills, has a high level or a high risk for serotonin syndrome, and it does react with virtually everything else. It works by decreasing the reuptake of serotonin, norepinephrine, dopamine, GABA, and glutamate. Then we've got our anxiolytics for anxiety. Benzodiazepines are short-term use. They are highly addictive. SSRIs are first line. We don't use barbiturates anymore. Hydroxyzine, Atarax, or Vistarol is an antihistamine with some anti-anxiety effects that may help. Beta blockers are not necessarily approved, but they can be effective in reducing the symptoms of anxiety, and that prevents that cycle from increasing. And then melatonin is being studied for preoperative anxiety. And then here are your benzodiazepines: Xanax, Valium, Librium. Librium was like candy in the 1960s. It was being prescribed for everybody, and then it became very addictive. Ativan and Halcyon. And there are a couple of other anti-anxiety anxiolytics out there. Lunesta, Rosarum, Sonata, and Ambien can be used for sleep. Don't recommend it. I have had a lot of history with colleagues where Ambien has caused DUIs in the middle of the night, collisions. People would not wake up and they'd go out and drive. Antipsychotics are thought to block dopamine 2 receptors, and Abilify is one of the most common. If you ever want just a good, funny experience here, go to GoodRx, put in Abilify or aripiprazole, and do a price check. You'll find $32 at Rite Aid before they closed, and $232 at Walgreens for the same pill. It's absolutely incredible. Huge price differences across the board. Antipsychotics are used for hallucinations, both visual and auditory, for insomnia, which they should not be counted on for that, but they do have an effect. In particular, Seroquel is frequently used for sleep. And then for anger and autistic patients, Abilify and risperidone are the only 2 medications actually approved for autistic anger and irritability. In 2013, Abilify had total sales of $14.6 billion. Anti-manic drugs are anti-epileptic drugs. The most common ones today are oxcarbazepine, also known as Trileptal, your Depakote, the valproic acid, and Lamictal or lamotrigine. The biggest issue with these, the biggest potential side effect is Stevens-Johnson syndrome. Folks with Han Chinese ancestry are much higher, at much higher risk of developing it. And wait a minute, here we go. This is Stevens-Johnson syndrome. And then the last point that I want to make is the MTHFR gene. You may have heard of this. It stands for methylene tetrahydrofolate reductase. It is a gene that controls the metabolism of folic acid into the chemical L-methylfolate, which is a precursor for serotonin, along with a bunch of other things. 1 in 16 people have a deficiency in this gene. What is kind of interesting is, and I've done genetic testing on, over the years, about 400 patients. About 50% of the ones I tested who had come in for mental health care have a deficiency, and about 80% of those with anxiety had a deficiency in this gene. It's interesting that the treatment for this is an over-the-counter preparation called L-methylfolate. Questions?
Wow,
No
this is
question.
great. There's nothing in the chat at this point. If you have a question, feel free to unmute yourself and go ahead and ask Dr. Daniels your question.
Let me figure out how I get rid of the screen and show me, but that's all right.
I have a couple things in the chat. Just a tremendous presentation. Thank you. No questions, but thank you so much for sharing. Another thank you. Thank you for including the information on methylfolate. Thank you. Very informative.
Oh, it was my pleasure. My email, larry@wldaniels.com. Primary, and don't hesitate if you have any questions to send me an email. And I don't mind taking this on the road every so often.
All right. Thank you again. We really appreciate your time and your expertise.
My pleasure. Y'all have a fabulous summer. Stay cool.
All right. Take care.